The goal of the Total IN.PACT study was to pool the data from four trials, IN.PACT SFA trials, to get a better understanding of the data that is more generalizable and applicable to a real-world population. So we had patients with longer lesion length, in cases of in-stent restenosis, more patients who had stents placed during the study, and we were able to perform subgroup analyses in order to get a better understanding of how to manage the patients that we typically see every day in our practice. The IN.PACT Admiral balloon is different from the other DCBs or drug-coated balloons that's on the market in that the dose of the paclitaxel is higher, so it's 3.5 micrograms. Also, the excipient is urea. And I would say that we have the longest outcome data with respect to the IN.PACT SFA trials for the Admiral balloon compared to the other platforms on the market. The design of the study was to pool the data from two randomized controlled trials and two single-arm trials. And we evaluated the outcomes with respect to imaging outcomes. And then we also, from that imaging subgroup, performed a propensity score matching subgroup and further evaluated the patients compared to standard PTA. The findings of the Total IN.PACT SFA trial was the persistent superiority of the IN.PACT Admiral balloon at 12 months when it comes to primary outcomes, primary patency, freedom from CDTLR, and also superiority of the safety profile compared to standard PTA. Well, you can never tell people what to do, but looking at the IN.PACT SFA data at present and the total IN.PACT SFA outcomes, we continue to see the superiority of the Admiral DCB balloon compared to standard PTA. With this study, we see it in patients with longer lesion length and also more complex patient and procedural characteristics. So if it were up to me, I would be a fan of using this balloon compared to standard PTA.